Welcome to episode 3 of Community Health Worker Data Dialogues, the podcast where we dive into how data is transforming community health worker programs around the world. I'm Dr. James O'Donovan, Director of Research at Community Health Impact Coalition, and I'm joined by my co-host Dickson and Mbeya, a community health worker from Malawi. In this episode, we're going to be speaking with DeRenzi from Dimagi and Kanishka Kantara from Living Goods to explore the role of digital in data-driven community health worker programs. But before we get into that conversation, let's start by hearing from Renata and Anastasia, community health workers from Brazil and Kenya, about their experiences as community health workers before the introduction of digital platforms.
Before the digital tool, we used pen and paper. We take care of a lot of people, and it was difficult to process and record all of the data, which is constantly changing. One day, a family has one reality, and the next day, a child is born, so you have to erase and rewrite everything. The lack of transparency was an issue. You could lose data a lot. For example, on a rainy day, you might lose all your notes. It was very time-consuming. The amount of paperwork was enormous. So when you needed an important piece of information, you might not be able to retrieve it quickly. Imagine a stack of paper, and you have to look through constantly changing data. Every month, everything changes.
So I might be having carrying that heavy book, and it rained. Everything will disappear. It might tear. If I have young kids in my house and replace my documents there, maybe I go for a short call shortly. I might find the young little have teared those documents. So I really every time I was missing the real data. So using manual books was very difficult for me. I never achieved any goal. Even I didn't know how many households I had in my area.
Now that we've heard from the community health workers, let's go to the studio and hear from Brian and Kanishka.
Nice to see you, James. Nice to see you, Dickson. And you, Kanishka, of course. I'm Brian DeRenzi. I'm the VP of Research and AI at Dimagi. I'm based here in London. My background is in tech. I've worked in this space for probably 20 years now. I spent a lot of time in the field in various places, but really excited to be here.
Amazing. Thanks so much, Brian, for making the time to come here, and really excited to have you as well. Kanishka?
Yeah, first of all, let me say a big thanks to you and your entire team for even hosting this session. It's such a proud moment for the larger community health movement globally. And I feel very humbled to be a part of this conversation. My name is Kanishka. I'm the Chief Digital Health Officer at Living Goods. I'm based out of Nairobi. And as part of my role, my core responsibility is to ensure the development of fit-for-purpose, successful and sustainable digital health solutions, which can drive the right data systems so that we can generate impact in the field and help save lives, which is the core mission of the organization. I'm a computer science engineer by qualification, but my education has taught me to be a problem solver.
Okay, great.
So, I just wanted to understand this issue of digitalization. Where did it come from? And why is it important that we can use digital issues in community health space? So, I have to start with you, Brian.
I think a big part of it is to enable real-time decision-making. So in the case, in the past, when you had 10 kgs worth of registers that you're filling out all those registers, and then at the end of the month, you're copying over some of that data and you're aggregating some pieces and submitting some forms, and those forms go to a supervisor who's then double checking or something, and it kind of trickles its way up. And once we digitize, one, it shrinks everything down. But the other advantage is that you get sort of near real-time data collection. And so you can shift as an organization, you can shift as a government to be making data-driven decisions. Often people are aspiring to make data-driven decisions already, but if they don't have the data, then those are kind of delayed in some way. But now you can actually respond in some real-time way, and you can start to think about monitoring for outbreaks or other things that really require real time, or looking at the impact of natural disasters or things like that to you get a much more holistic picture, and you can think about how you're distributing and allocating resources to be able to respond effectively to make sure that everybody's getting the best outcome possible.
We heard from Brian about why the shift to digital is important and helps with real-time decision-making. This is also true for community health workers, so let's hear from a community health worker in Brazil about how this shift has helped her.
We have also saved a lot of time with digitization. Previously, if I needed to check how many hypertensive patients we had, I had to search through my notebook and count manually. I would update my list, but sometimes I needed to double check. Today, with a click, I instantly know how many hypertensive patients we have. So we save time, and the information is more accurate because of real-time updates. Data inconsistencies are flagged immediately. If I enter incorrect information, the app detects the error right away. So I believe that digital tools have optimized our work significantly.
If you ask me, in my 20 years of experience, if you actually want my advice, that you want to digitalize, my first question will be, what is the scale you're talking about? Because again, there is no, hard any study on this, and I think that needs to be done on the ROI of digitalization. Digitalization is not cheap. It's a very cost-intensive, time-intensive, and a resource-intensive activity. So if you're talking of a 50 CHW scale, or 100 CHW scale, or some small scale without having the larger target, I'll actually say, don't. You rather invest that money in buying vaccines and medicines and just giving to the CHWs. That will possibly save more lives. But if you talk of doing the same activity at scale, 1,000, 2,000, 5,000, 50,000, there is no way to actually do it in a transparent and effective manner, but to adopt digital. There is no way you can do that real-time decision-making without having these systems in place. So I think my answer is on the scale. I bet, giving one smartphone to one CHW versus one vaccine to one CHW, the odds are heavily in favor of giving a vaccine that will absolutely save one life. A smartphone might not. But you multiply it by 50,000 user scale, it completely changes.
In the early days when we were trying to understand how mobile tools could help health workers with the work that we were doing, we were working with another HIV program, and these community health workers were doing kind of wellness visits. And I remember sitting in on one in particular in Tanzania, and it started off fine. They kind of had a normal conversation, and then at a certain point, the client, who was HIV positive, kind of broke down and started crying. And she told this story about how she was HIV positive. She was living with her auntie in Dar es Salaam, in the capital of Tanzania, but her family back in a rural area in the village were asking her to move back because of, at the time, the heavy stigma of HIV, and they were ashamed that she was HIV positive, and they wanted her to move back to the village. But the antiretroviral drugs that she was using to suppress the viral load and kind of keep herself healthy, they weren't available back there. And so she was describing this incredible pressure from the family to basically move back to the village and die. Which would have been awful, obviously, and it was it was a heartbreaking, obviously, to listen to that story. It was beautiful to see how the community health worker reacted. Any mobile device that happened to be there was set aside, and it was met with empathy, and it was met with all of the very human, very important emotions and support that was needed in that moment. We're just building some tools to help support some stuff. The real work is being done by these community health workers and by these individuals. And I think it's important to keep that in mind. And Kantara Toyama, who's a computer scientist, he used to run the Technology and Emerging Markets group at MSR India. He, for a while, was talking about this idea of amplification theory, but the idea that technology just amplifies human intent. So if you have a community health worker who's already going out and delivering the support and care that people need, technology can be a way to kind of amplify that intent that they already have. And I think that's important to kind of keep in mind when we talk about or think about digital or think about how it affects things in public health. It's really, it comes back to those community health workers who are doing that really critical work. And if there's a way that we can better support them or improve service delivery by giving them the tools that they need, or help them to collect and aggregate data so that they can make more real-time decisions, I think that's the role that digital has to play.
No, that's fantastic, Brian. Well, thanks, first of all, for sharing that story. It was very powerful testimony. And also, you're incredibly modest when you said we just build some tools. We're gonna come on and talk about that, and really excited to hear about that. I know Dickson's got a question around this, but I think the key take home there for me as well is that we do talk about digital and scaling and the ability to unify data. And I know at the beginning we talked about quantification, but sometimes it's quite easy to forget or overlook that human side, which is so important. So yeah, it was very fascinating to hear that the community health work kind of just set aside the digital technologies, which obviously you can sometimes just become absorbed in. So I think not forgetting that human aspect is so important.
Another question would be, what are the common tools and platforms, systems that are used for data collection?
Again, let me just structure the digital ecosystem in terms of the data collection layer, the data visualization layer, and then what happens after that.
That'd be super helpful.
Yeah. So at the data collection layer, of course, the smartphones are the biggest tool which is being used to collect data, which is used to empower the community health workers by designing smart applications. Now, these applications can be built on some well-known platforms like, ComCare by Dimagi, or CHT by Medic, or, OpenSRP by ONA, or there are so many good products out there. But of course, these three are the leading case management platforms which are being used by the community. At the data collection layer, again, there are so many softwares and tools, and I can keep on talking about it. But the idea is, how do we use internet? How do we use that ability to deliver service and then design tools which are user-centric so that they are not actively collecting data? Data collection actually is passive. The focus is on service delivery. And that's where I think what Brian referred to is also around the need to put the end user, at the center of this entire tech stack. And then, of course, at the data visualization layer, it's how do we design dashboards for different stakeholders, right from the community health worker, because if I'm collecting some data, if I'm doing service delivery, I should be able to know what is due, what is pending. Data-driven tasking should be enabled at that layer. What is the summarized progress of what I'm making, and where am I missing targets? Similarly, at the supervisory layer, which is, again, one of the most oversighted layers in this entire sector. But in our own work, we have seen the criticality, the evidence of how important that supervisory layer is to drive impact, to course correct, and then to help the community health workers to understand the value of what they are doing. What type of tools are available at their end? Again, I'm really simplifying when I say that they just have a tablet or a smartphone in their hands. But what exists on that tablet and the smartphone? It could be around e-learning. It could be, tying their performance with what they need to learn more, how they are looking at the CHW workforce, who is a fast learner, who is a slow learner, who is doing well. Maybe there are aspects of their job which they are not doing well. So is there a need for them to prescribe a specific e-learning course or an in-person training? But this is all based on the tools which are in their hands and how the data is being collected and generated and visualized, and the follow-up action which is being driven with the use of that data. Coming on top of these two layers is actually the managerial roles, which is where, again, the dashboards become important. And the way we have always looked at these dashboards is not an MIS. And Brian and I are ex-colleagues, from my Dimagi days, a long time back. But that is something which we have, as an organization also, we have imbibed that this is not about an MIS. This is about telling specific individuals what are their priority areas. how is the data going to inform them, how the data is converted into information, and then from a knowledge standpoint, so that trends can be established.
Right.
And that's where, there is increasing chatter about artificial intelligence in this space. But before we talk of artificial intelligence, we need to talk of basic intelligence. We need to talk of the capacity building at that level. Are we even enabling that? I think, let me also say this, and the larger sector of community health is now very ambitiously adopting or has just adopted digital at scale. And the adoption of technology at scale and tools at scale has its own life journey. With that, and without getting into what it means, but with that also comes the capacity to build that ability to process data. These systems have been based on paper-based systems. So the data journey has been a very slow journey from the field to the decision-making level. Now, suddenly with the advent and adoption of digital tools at different levels, specifically at the top level also, the dashboard level, suddenly the data is becoming available very, very quickly. Now, how is that capacity going to be generated so that data which is suddenly coming in, how will that be used? So tools around that, how do you help them? Sometimes it's manual support, helping the policymakers, helping the different stakeholders understand this is how you use data. Can we develop modules around it? Can we develop examples which can be used for a broader cross-learning? So again, I have not gone into the specific tools which we use, but I hope I have answered it at a broader ecosystem level.
Yeah, that's fantastic. I think that gives us a really good kind of like broad ecosystem overview. I would like to actually, I've got loads of questions that have come out of that. It would be good to know a little bit about the tools. I know you mentioned several there, but maybe Brian, I can ask you specifically about Dimagi and ComCare Connect. If you could break that down on a very simple level for us to understand what it is, how it works, and the levels or layers that you guys have gone through as you've iterated on this.
Yeah. So fundamentally, ComCare is a platform for supporting frontline workers. We've worked in a number of different domains. Health is far and away the largest domain and sector that we've worked in. And so it starts from the frontline worker. So building it's a no-code platform that allows somebody to put together a smartphone application that can run on a mobile device to support service delivery. And just as Kanishka was talking about, the goal when people put these together is to make data collection a byproduct of service delivery.
Okay.
So build a tool to support organizing the set of individuals they're following up with. A very common use case, I think, in these settings with community health workers is that they might have a set of they'll have some catchment area and a set of households or individuals that they need to follow up on. So maybe it's that they're following up with children and checking nutrition status. Maybe that's around pregnant women. Maybe it's around, TB positive or HIV positive individuals, et cetera. And so those would get registered in the system. It maintains a list of all of those individuals on the phone, and then they can follow up and kind of update that record and provide additional information. And when we talk about data collection being a byproduct of service delivery, it depends completely on the program, but a lot of programs will put multimedia content that's meant to be shared directly with the client in local language as a way of kind of boosting and backstopping the messages that the community health worker is putting through. And things like this. There'll be checklists for kind of healthy actions. So like a pregnant woman, maybe there's, a half dozen things that they need to do while they're pregnant. Get a tetanus booster and get an HIV test, take your iron folic acid, et cetera. And so you'd be kind of keeping track of all that, and that kind of goes through. So that's the ComCare platform. There's a web-based platform where, again, with no code, you can put together that application. There's some management around all of those different devices, and then all of that data gets pushed back to the web-based ComCare platform. And then at that point, you can integrate with other systems. You can build dashboards like Kanishka was alluding to, et cetera. So that's kind of the main community, or at least the way that ComCare does it to support community health workers.
That's fascinating. And I might just ask Dickson, actually. I'm interested to know so I know, Kanishka, you were saying that, by far and away, the most common hardware used is a smartphone. Is that the case with you, Dickson? Do you use?
Yeah. We use like those small phones for taking data. Yeah, that was quite right.
Okay. And what kind of platforms do you use on the smartphone? Do you have like particular programs or apps or services that you use?
Yeah, actually, we have those apps that have been installed in the phones. So it depends on what data you want to collect.
Right.
So yeah, through those apps is when you collect data using those apps. Then some data is just sent directly to the server, and others can be extracted from the hardware itself.
Yeah. And I know this morning when we were talking earlier on episode 1 with Tracy McNeil at Gates Foundation, she was saying one of the problems was this sort of siloed approach to data collection. So community health workers might have 4, 5, 6 smartphones with multiple different apps. I don't know from your end as Brian and Kanishka, from a development perspective, if you've got any thoughts on this or even, look, I know we've spoken about the benefits here of digital, but I would like to sort of push you guys and see if you can tell us any of the kind of drawbacks, downsides, or challenges that you've found with this.
Yeah, I can talk a little bit about some of the work that we're doing that's a little more forward-looking, which is I've described the ComCare platform. That's something that's out, it exists. We've been working on it for 20 years. It's quite stable. It's scaled up to hundreds of thousands of concurrent users. Kanishka's smiling because he was a big part of a lot of that work. And one of the initiatives that we're focused on right now is called ComCare Connect. And the idea is to support community health workers to deliver additional work for additional pay. And the idea is that through the ComCare Connect platform, community health workers can learn. We can do some training through the ComCare platform. We can support service delivery. We can validate that the service has been delivered, and then they can get paid for additional work. And the real goal there is to improve the impact per dollar. Are there ways that we can get money directly into the hands of the community health workers who are delivering it to make things a bit more efficient and support them to do additional work? I think it's often the case that there are a number of different interventions that we know are useful and impactful and have good cost to benefit ratio, but can't always be funded by the government. And so external groups will often kind of fund or top those up. Is there a way that we can do that and kind of cut out some of the middlemen and support the community health workers directly to be able to do that work and get most of that money into their hands and into the country to be able to deliver those in the most cost-effective manner as possible?
That's fantastic. Kanishka?
Yeah. As Brian was talking, I went down the memory lane.
Yeah.
lot of, fond memories of the impact of digital adoption at scale in a big program in India. That was the nutrition program of India, and very similar stories are coming out from different parts of Africa. The work we are doing in Kenya, Uganda, Burkina, it's not very different from there. I think you referred to some of the core challenges which are around digitalization aspects, and I know I can absolutely talk about the tech side of challenges of what needs to happen and what is not happening and what are the gaps. But I think just on the human side of adoption as well, and which is where I was, down in my memory. In the India program, what had happened is that there were 11 monthly registers, like big paper books, which were being maintained by the community health workers. And those 11 paper registers were replaced by one single mobile app. And we had done, a broad, very high level assessment. And it showed that practically some 11 kilograms of registers, which they were used to handle every day, were replaced by some 250 grams worth of a smartphone in their hands. And the bigger impact was the reduction of duplication of efforts, which they used to do on a paper, on a paper format every single month for every single beneficiary. Now that was a big advantage and the value which was drawn by the community health workers, the end users. But at the same time, when one thing works, it becomes a solution for every single problem in the ecosystem. So suddenly there was an explosion of multiple applications coming on the same phone at the community health worker level. And the duplication which we had avoided by replacing those 11 registers suddenly started appearing by the intervention of different programs, trying to ride on the same success and the same wave, which is not wrong, I think, but there is a need to have a broader system design perspective around this.
Right.
Are we actually solving for something by using digital, or are we replacing 11 registers by 11 applications on the same phone?
Yeah.
I think that's where the user at the center becomes the key around successful tech adoption.
So we've heard about the challenges of multiple applications, but let's now hear directly from Deborah, a community health worker from Kenya, about the multiple challenges that she faces.
At times you find there's an head-on coalition with collecting data for different organizations because it's like you're redoing your job over and over again. So it's like the job is becoming bulky because it is the same under one I collected for a different organization, the same under one I have to collect for the sub-county or maybe for the county. So it becomes bulky in terms of collecting data. We have to use different phones, sometimes different apps. There are times we are even forced to go back to paper. There are some data that comes that you have to write. Currently, in my sub-county, we have an organization called CHW. It is based on tracking under 5s who have defaulted for immunization. My ICHIS tool also, my digital phone, I also collect the under 5s. So it's like repeating my work over and over again.
You're now going to hear from Julius Mbeya, Co-CEO at Lwala Community Health Alliance, about how they've used digital technologies in their community health worker program in Kenya and his reflections on this.
In Kenya, we are coming from a place where community health workers were using paper-based record systems. Those paper-based systems were heavy registers that were unavailable for community health workers because government could only produce a number. And when changes happened to those registers, it took so long for those registers to be printed and be made available for community health workers. So it was not uncommon that community health workers would be using registers that were 2-3 years obsolete. The digitization process was part and parcel of trying to address this problem, and more importantly, to be able to create a decision support mechanism for community health workers to be able to collect more standardized data, but also in the course of offering their services, they can actually be more accurate in using the protocols that have been developed for them by the Ministry of Health. This journey saw the testing of different applications across the country, where different organizations were using different solutions in an attempt to digitize the work that they were doing, until around 5 years ago, that real impetus was created for creating a national digital platform for community health workers. A national landscape was carried out, which ensured that we understood other digital solutions that were existing in the space. And over time, that morphed into understanding minimum system requirements for a digitized community health system. Different platforms were studied, and at the end of it, we came up with the electronic community health information system that runs on the CHT platform or the community health toolkit. This electronic community health information system was developed out of understanding the various workflows that community health workers deliver and ensuring that those were standardized and intuitive enough for use by community health workers. As Lwala, we played a key part in the design process, working with organizations like Living Goods and Medic, AMREF, and others to ensure that we were having a common understanding with the Ministry of Health that the workflows that were being built were the relevant ones and were meeting the standards set by the Ministry of Health. And collectively, this got tested and eventually rolled out to community health workers. We have continued on that journey, and right now, the Ministry of Health through the government of Kenya has made great investments in digitized community health workers. That has meant that all the over 100,000 community health workers are now onboarded onto the electronic community health information system, and that system is being used to collect data by community health workers from across the country. Part of that is also to think more broadly about the utilization of this data. And what has happened is that we've managed to create linkage between the ECHIS, or Electronic Community Health Information System, and the National Health Data Platform, KHIS. That integration means that we are now able to see data move from the work of community health workers and get it aggregated at the national level. That aggregated data is helpful in helping read trends, see the disease patterns, and the investments that the Ministry of Health needs to put in place, and the government, to ensure that populations are kept safer.
Something I did want to ask both of you actually is, okay, we know we need to involve community health workers more closely in the design of digital tools. Practically, how do we go about doing this? It seems like an obvious ask, but also at the same time a very challenging one. I don't know if you've got personal past experiences where you've seen this done well, or you have ideas in terms of the organizations that you're working for, what they're doing about this. Perhaps, Brian, I can start with you and then move to Kanishka.
Yeah, in the early days of ComCare, I spent a lot of time with community health workers, and that was both shadowing them on home visits that they were doing, getting together in focus groups to kind of discuss and understand where their challenges were and think about usability issues with it. And we had quite a fun cycle in sort of those early days where I would get together with a bunch of health workers. We'd chat about some things. They'd say, oh, this isn't working, or that's not working, or maybe we can improve that. We'd kind of brainstorm, come up with some ideas. And then I'd go home and write a bunch of code until I fell asleep. And then my colleagues in Boston would write a little more code until I woke up. And then, we'd load a new version on the next day and kind of iterate that way. And probably the first, 50, 100 health workers who used ComCare, I had a personal relationship with at some point. And at Dimagi, we have this, we talk about our version of human-centered design. We call it design under the mango tree. And that's because when I was in Tanzania and when we were doing that work, there was actually a mango tree that we'd sit under with the community health workers. And we did everything from little paper prototyping to, low fidelity prototypes of various versions and just kind of iterate with them to understand. And there were, just to name a couple, there were so many features and kind of ideas that came out of that. One that was sort of obvious in retrospect was they wanted some like password or PIN code or something. This was before smartphones, back when we were doing stuff on J2ME, but they wanted a PIN code when you open the application, because we were working with, I think that was one of the HIV programs that I was mentioning earlier. And they said, look, if somebody picks up the phone and they open that app and they see a list of patients, now you've just disclosed who's HIV positive to that person. Like, we need a PIN code or something to, like, yeah, of course. And so, code all night and talk to the team. And eventually we got some login. And, so many of the features of the ComCare platform really came out of that sort of direct use and direct need and, walking with people and working directly with them to kind of understand how it fits in the sort of experience that they're having with their clients directly.
No, I love that. And I love how you said, walking with them. I think it's a term that Paul Farmer used to use a lot around, like, walking with people or accompaniment. It's so important. Kanishka, I don't know if you've got similar sort of past experiences. I'm sure in the 6,000 plus days that you've been working, you have many. I don't know if you've got a highlight that you'd like to share.
Well, it's actually close to 7,000 now, but okay. that's not the point. I think this is absolutely true what Brian said. This has been my personal experience also, not only in Living Goods, which, like, we vouch for this approach. We not only in spirit, but in practice also, we ensure when we are designing digital tools, when we are designing those workflows, we don't, like, I personally do not approve the release of those till the time it has been tested and it has been, verified by the end users. And let me just elevate that. I think it's not only about technology. You look around the public spaces. A lot of times the governments do get it right. The design of the subways, the design of the overpasses, but the number of accidents which still happen,
right,
globally, is also because a lot of the times we are not getting those basic designs right, because someone is designing without keeping the pedestrian in mind, without understanding how the pedestrian is going to use this, underpass or the overpass. The same is true for technology. We designed by, and I was guilty of that till about 10 years back, till the time I moved to the development sector. That is when I started realizing that there is more to this. It's easy to believe that I know this stuff. I know what is needed by the end user. And that's a very different perspective. In fact, and I bet, some of you will be multilingual. Some of us are multilingual, actually, even within this room. If I am asked to type a message in my mother tongue, which is Hindi, I'll find it incredibly tough to type it on a smartphone versus typing it in English, because I have always used English as my primary language to use a smartphone or a laptop. But you look at it from a community health worker standpoint, she has always used Hindi or whatever the local dialect is. Now, as a computer science engineer, I will never get to that point till the time I go to the field. So our basic construct, as Brian referred to, even living goods, we ensure that voice of the end user is the most important voice of what needs to work. But it's easier said than done. Let me also say this, because people like Brian and I can always talk about it all day. And I think this is simple logic. This is common sense, which all of us have. But why it becomes difficult to implement in the technology world is because Googles and the Apples of the world have given a perception that technology is very easy. And that leads to, the expectation that this is so easy, guys. Why do you need 8 months to develop this? When I've seen my family, I've seen my dad, when someone used to come to him, no one came to him telling him, give me this antibiotic, give me this medicine, I'm sick. Everyone came to him by saying, I'm not feeling well. I'm having headache, I'm having nausea, I'm having something. And then he will diagnose and he will prescribe the medicines. And Brian, please jump in. But when people come to techies like us, they're not coming with a problem statement. They're coming, we know the solution, just do this. And that's where it's an added responsibility on voices like us to ensure that the voice of the end user is still in the picture. And it becomes increasingly difficult to do at scale, because then technology looks easy from a distance.
And, how do you push back in that situation? I imagine, now perhaps because you're both working for very large, well-respected organizations in Dimagi and Living Goods, it might be easy when you have that ethos behind the organization that it allows you to give that pushback. But, how would you advise others who might be listening to this podcast thinking, look, I completely agree with you guys, but I can hear what you're saying in terms of tech wanting to move fast and at pace. And, we've also discussed in this podcast the need to bring in the human side of this. Yeah, practically, how would you advise going about doing that?
Let me just slightly refine what you said. It's not tech wanting to move fast. It's the stakeholders wanting the tech to move fast. I think what I will say is look at the evidence. I don't know, one of the big advisory groups actually came up with this study a few years back, which showed that 80-85% of the big projects do not fail because of technology. They actually fail because of change management not being managed properly. And that's the human side of story. In my own work, I obviously deal with a lot of medical professionals. And you can, put it on my family background. But I take a lot of medical examples. A vaccine takes 10 years to develop. You need to do clinical trials. You need to work with those subjects to see how the vaccine works or the specific medicine works. Only then you put it for approvals and manufacturing. Software for the end users, and that's a very different layer of the users we are talking about. They're not digitally as savvy as we are. we have to consider their voice from a retention and adoption standpoint. And that's where the evidence, the data speaks about itself. So as an organization, we also focus a lot on not only on the service delivery data, but also on the metadata of the system. Is there a particular workflow, a particular aspect of the system or the application in the hands of the workers being used more than the others? Because sometimes it throws interesting insights. A small change in the workflow can lead to a big change in terms of adoption and understanding, and which leads to data quality, improved data quality as well. I'm not saying this is the only way to improve data quality, but it can actually lead to that. But this evidence, when you put it out there, in terms of process input, output, and outcomes, when you're able to put, these 4 buckets together and put data in each bucket, it's very straight away. It's a very simple argument. Not a simple argument, but it's a straightforward argument. And then, of course, you have to bring in the experts so that their voices are also heard. But Brian, I'm sure you might have more examples of this, of how do you engage with your stakeholders?
Carefully. I think, I was reminded of the proverb, if you want to go fast, go alone, and if you want to go far, go together. Yeah. And the reason that I was reminded by that is in the early days when we were just getting into digital and we were trying to digitize some of these community health programs, we would have a conversation with the worldwide headquarter of the partner, and they'd say, oh yeah, the program works like, XYZ. And you're like, okay, cool. And then you get down to the country office and they're like, no, that's not exactly how it works. It works this other way. And you're like, oh, okay, fine, we'll shift a little bit. And then you get down to the field office and they're like, no, it's a little bit different. And then you actually go and spend some time with the community health workers. And by the time you get there, it's, you've had 3-4 evolutions of the thing, and it's completely disjointed from what the world office thinks is the... And I think there is no replacement for spending the time. That's why the proverb, but there's no replacement for spending the time with the health workers. I remember one particular organization, we'll leave them unnamed, but they had these community health workers who were doing they were doing like 20 home visits per day. And they had these ledger books that were all filled out really well. And we're like, oh, this is an amazing amount of work. You guys are so efficient. Everything's going great. And we spent a bunch of time with these community health workers, and we're having all of these focus group sessions with them. And after some weeks of building that relationship, the focus group ended and we were standing around and we were chatting to some of the health workers, and they were like, looked around a little bit and said, listen, we don't actually do all this work, right? And we're like, what? And they were like, yeah, the organization pushes so hard that we have the ledger books filled out, that we make sure that we fill out the ledger books. And they're like, but we can't possibly do this number of, it's a completely unreasonable number of visits to actually be able to achieve that. People aren't home. They're out in the field during the day, you stop by the home, whatever. And so, and that level of honesty and kind of transparency, it's only something that comes from building the relationship and spending the time. So I don't think there's a way to kind of shortcut that. And I think it's essential to really have that where you're all going together so you can actually get to the destination.
Yeah, no, that's a fascinating insight, actually. So are you saying that, the 20 home visits where the data was collected, that data actually sometimes was just input incorrectly, or they wouldn't necessarily have done the visits?
Not to, this is many years ago. Yeah. Everybody's safe. But I think they basically said maybe we do 5 or 6 of those visits, and then we just kind of copy from the previous visit and say everything's fine at that household as well for the next 15.
And can digital somehow stop that sort of, I know we're going to talk in another episode a lot more about data quality, but from your own experience, have you seen any way that digital can somehow address some of these concerns around incorrect data input? Again, I understand that, we need to be designing the programs in line. They shouldn't be doing 20 home visits in the first place. Maybe we should be down to 5. But I don't know if you've seen any ways that digital can help with this.
Yeah, I think in that particular case, you're right. It was a design problem that they had an unrealistic expectation for the amount of work and unrealistic requirements. And I think in that case, it had to do with kind of shifting countries. And, in some countries, all the houses are kind of clustered together, and then everybody goes out to the fields. And in some cases, the houses are kind of spread apart where there's kind of one per field. And so it's, I think maybe they were lifting a design from one place and trying to apply it to another. In terms of digital enabling some investigation of data quality. I think, there's a big part of that's happening with us with CommCare Connect. I mentioned briefly the validation step. So there's both validation and auditing that happens during our CommCare Connect programs. And so we can look at things like, with modern smartphones, we have the ability to look at GPS traces. That's often something that's used, or even things that are simple as kind of the amount of time between data entry elements, or how long they spend entering data or kind of using the application, because they're meant to be used in situ while they're in front of the client. And so if they're able to, if one data entry form takes 30 seconds, probably they weren't doing it with the client right there. Or if there's 10 seconds between multiple data entry, you can start to kind of see some of these things. And so we do some basic heuristics to look at outliers and things like that to try to validate some of the work that's being done.
From a funding perspective, how do you make digital integration and enhancement sustainable? I know that Dimagi have been thinking about this a lot, but it would be good just to get your thoughts on this.
Yeah, it's a good question. I think, in some ways, Dimagi's entire goal is to find sustainability. And I think our experience is it needs to be owned by and built out by the government. So I think we're working with 9 different countries in Africa that have committed to going to scale and using CommCare in various ways. So, for example, in Ethiopia. And I think we're working with Living Goods on this project as well. We're working with them in Burkina. We might not be colleagues at the same company at the moment, but still collaborating heavily.
That's a question also I want to just ask you later.
Yeah.
How much do you guys work together in terms of, Dimagi, Living Goods? I know we've spoken about Medic. It would be good just later on to get a sense of that, but yeah, please continue.
Yeah, I've got some thoughts. So like in Ethiopia, for example, the government is using the CommCare platform. Everything's open source. They can do whatever they want with it. And so they have their own servers in Ethiopia where they're running their own instance of CommCare. They have their own developers who are developing their own CommCare applications using that no-code platform and be able to collect and manage that data. All the data stays in Ethiopia. So that kind of solves the data sovereignty problem. And I think Dimagi's role and I think Living Goods' role has really just been to provide support to the government if they need help with getting those servers up and running, or they want to do some additional thing that wasn't there before. We can kind of help support in all those pieces. But it's very much built out by the Ethiopian government. It's very much run by the Ethiopian government. And owned by them. And I think that's the way that these things become sustainable. I mean, like the government has to buy in. It has to be, if you want to, Kanishka was just talking about scale. And if you want to scale to an entire population, it has to be run from a government system. The public health system is largely what exists in many of these countries and serving the populations that we're most concerned about. So if they're the ones running the community health program, it's got to be their buy-in to make this happen.
Can I just add to what Brian said? I think in the development sector, one thing which I personally believe we have been missing out is what does sustainability actually mean? Right. We have been broadly looking at it from the perspective of financial sustainability. Don't get me wrong, that is really a really critical piece of how do we make a program financially sustainable. But in that focus, we have been missing out on what will make it financially sustainable in the first place. And that's the value the system is going to create for the stakeholders, for the consumers of the system, for the beneficiaries of the system, including the governments themselves. And, there are so many examples where as a common citizen, I'm willing to pay for the fee, for the service, because I feel the value which is being generated by that system. And I can absolutely call out a system like M-Pesa in Kenya, where there's a very small transactional amount, which is, the platform charges, from the end consumer. But everyone is willing to pay for that because it is generating value for the end consumer. I think that's where the financial sustainability starts. If the programmatic sustainability can be achieved for these systems, which means the value for the end stakeholder or the consumer of the system is there. We can ensure that the financial sustainability follows that. And to what Brian said, absolutely, there is no question that at scale, governments have to be the owner of this. Governments have to lead the way and show the way. And partners like us have a very important role to help them to navigate this path. And that brings me to the point of the fundamentals of technology. At scale, technology is a very different animal. The fundamentals which are needed, it's not about the smartphone in the hands anymore. It's also about what will make that system work at the back end. The entire data infrastructure, the hosting environment, the connectivity environment, everything which remains invisible. It's that below the surface iceberg, which I'm talking about. All we see is the tip of the iceberg.
Yeah, right.
The 70% of the iceberg is below the water. It's not the tip of the iceberg which sank Titanic. It's the below the water iceberg which sank the Titanic. And that is what happens with technology at scale. So I think that's where the fundamentals of technology need to be put in place when we talk of technology, at scale deployment.
That's actually a really fascinating analogy you've just drawn there. And, have you had any experience with when you say talking to funders, do they appreciate the 70% or 80, 90% below the water? Or is the focus mainly on the 10% above the water? Or, what's been your perception, again, working with funders around their appreciation of this and the complexity of how you've dealt with things at scale?
I'm going to defer to my colleague Kanishka here. I think he's been more in the trenches on that. My quick answer is, it varies, of course. Some funders, some individuals at funding organizations will understand this more or less. Some are spending years trying to kind of move the needle and work closely with governments and kind of make that happen. But Kanishka, over to you.
It's a mixed bag, to be honest. There are leaders in the space, in the funding community who understand this because they have either experienced it, they have learned it, or they're coming from like a similar background of tech where they actually understand how the tech works at scale. But at the same time, there are pockets where it's very easy. It looks so easy. It's more about the workflow rather than what it looks like, the engine which is needed to make this work. Which is where I think the role of someone like me and Brian and like the cohort which we have is so important to help increase that level of awareness for this larger funding community as well as for the government stakeholders. Because I think the biggest misconception, and we see it at scale in the government programs in every single country. When we talk of technology at scale, it is the perception, unfortunately, is that it's like a WhatsApp. You just need to develop a couple of workflows, deploy it, and then everything else, someone will take care of that. Whereas it's a bit more complicated than that. And that is where the level of awareness, and we have been spending a lot of time as Living Goods to work with our stakeholders, both in the donor community as well as with the government stakeholders, to help them understand that how do you look out not for today or tomorrow? How do you plan for a year, 2 years, 3 years down the line? Because that's where the success lies. Today it will work, but in a year's time we will have challenges. So how do you plan for that? And there is a way it can be done.
That's fantastic. Have you got any questions?
Yeah, as computer engineers, do you have that time, that chance that will bring CHWs on the table and maybe ask ideas on how you can develop some of the applications in data collection regarding community health work?
Yeah, especially at scale, I guess. So it could be easy to bring community health workers on board when, you're operating at small scale, like 50, 100. Yeah. But what happens when you're operating, 50,000, 100,000?
Yeah, maybe one thing I'll say, so certainly at small scale, we did a lot of that in the early days when we were trying to figure out what CommCare was, how to make it work, how to integrate it into the workflows of community health workers. And it's always easy to think about when you're starting a new project or some innovation area, and you start with your 20, 50, 100 community health workers to kind of go deep. Maybe the thing I'll say is one of those lessons that we learned early on that we talked about earlier, which is to provide two-way communication and to provide mechanisms for CHWs to feed that information back. I think this kind of goes hand in hand with one of the bigger challenges of community health programs is they're often under-supported from a supervision standpoint. And so really providing mechanisms to get that kind of continuous feedback. One thing we found in a program was the community health workers were collecting data, and somebody had done an analysis, and they decided that there was some information that was perhaps not 100% on the up and up. And so they decided to tell the community health workers, hey, we looked at your data, and it seems like some of it was a little bit dodgy. And the data quality the next month just like spiked. It jumped right up, and things really went a lot better. And we've found that to be true working with different partners is if you feed that information back, if you're, nobody wants to fill out a form and put it through the mail slot and nothing happens from it, and there's no kind of feedback or follow-up or something. And so I think having that sort of continuity of communication and feedback bidirectionally, so that community health workers can say, hey, this thing isn't working for me, let's figure out how to change it. Or, systems can say, hey, based on this data that you've collected, we're going to reflect that back to you so you can see how you're doing and how your communities are doing. I think that communication flow needs to be going both directions, and I think that's the best way. But from a system standpoint or from an organization standpoint, having governments to have representatives from community health workers who can be kind of feeding that information back in addition to the technology piece, I think would all be very positive.
Yeah, that's fantastic. I've got sort of just a pivot away slightly to a different topic. I did want to ask about the sort of gender digital divide. So we know that the vast majority of community health workers are women. We've heard just earlier on this podcast from Millicent Maruka, a female community health worker from Lwala, living and working in Kenya. But I just wanted to ask from your perspectives, how do we make sure that when digital interventions are integrated into community health worker programs, women, female community health workers aren't left behind? Have you got any thoughts on this or ideas about how this has been done well at either of your organizations?
Yeah, I'm happy to start. Dimagi is a tech company at its core. And so we build a platform, and that platform gets used in various locations. And as you mentioned, there are some in Pakistan, they have lady health workers, right? And those an entirely female cadre set of health workers. Obviously in Malawi, it's mixed. And so different countries have kind of a different gender makeup of the populations. And I think different countries have different challenges as well. In some countries, many countries, access to digital devices is lower, which can make things a little bit more challenging. So I think a lot of it comes to the training. From the platform side of things, the main thing that we can do is support a range of digital and I guess written literacy as well. So the platform supports using audio or using picture or video within the application to make it easier to navigate. We've done a lot of that kind of co-design under the mango tree work to really try to understand and meet our users where they are. The other thing that I'll say is it's often the case that community health workers are a little bit older in their, often they've had their kids have been raised, and so they're kind of a little bit older, and so you run into some of that digital literacy or even just eyesight. If you have, certainly in the days before smartphones, when we had those little J2ME phones, the screens were tiny and the text was tiny. And so kind of navigating that and trying to find ways to support the community health workers that we're doing there. But I think it really just comes back to the individuals and including them and building out in an inclusive way to make sure that we're not leaving folks behind.
Yeah, it's a very interesting question. I think we also need to talk on a couple of aspects around this, in addition to what Brian talked about. I think one is around the change management at the societal level. And second is around the professionalization agenda and how is it having an impact on this gender equation within the community health ecosystem. Yeah, I mean, I'll quickly touch upon the first one. I was on a field visit in a remote part of Uganda a few years back during my early days in living goods. And one of the things which really stood out for me, and I've seen that happen in so many other countries as well. It's not about Uganda or Kenya. It's I think prevalent at every country at the local level, is whenever the society or the community sees something new in the hands of the community health worker, there is always a sense of curiosity and a sense of suspicion that what is this new tool? Because as a society, we have not seen that till that particular day in time. Now, all of us have been focused on the enablement and the empowerment of the community health worker, that cadre. But we have not paid enough attention of how this will be received at the local community level. So obviously there was suspicion that what is this new tool? What are you doing with this tool? So you were using paper and pen. So what are you doing with this? Like, what's going to happen with this? So obviously there was a bit of a resistance in terms of that adoption by the community health workers at the local level. And during the initial days, they actually were still using paper and pen. And then slowly that change happened. I think what also benefited, and again, this was a bit of a surprise for me to learn, is when the community was able to see tangible benefits coming out of this system, that suddenly the vaccinations are, getting provided to the children, or the sick child assessment for malaria, and, accordingly the referrals are happening. They started, the community members started to relate it to, oh, this is a new thing. And now suddenly we are seeing better service delivery. So that sense of, oh, is this a conspiracy against us? Is there something, that suspicion got dissolved in a big way. And of course, during the COVID days when the vaccination started coming in, that these tools went a long way in terms of strengthening that last mile, but we call it the first mile because from a community standpoint, that's the first point of contact to healthcare access. That first mile suddenly got that enablement, at least in the places where these tools were deployed, where living goods we were operating in Kenya, Uganda, and Burkina. That changed a lot of perception. So one of the big takeaways for us as an organization has been that we cannot discount the community change management aspect of it. How do we connect with the leaders in the community to help them educate that how is this going to make a difference? What is this all about? Coming close to that is also the community health worker herself. In the 3 countries we operate in, Burkina, it's a 50-50 ratio between male and female. But in Uganda and Kenya, it's an overwhelmingly a female-dominated cadre we are talking about. There are, of course, male community health workers also. I think that's where I feel that professionalization agenda is playing a big part. Because so far, remember, these were not the CHWs. They were the CHVs, community health volunteers. Now, with the strong advocacy and the evidence being put on the table, governments have started to recognize the value of this layer of public health. And suddenly, a number of governments have started to ensure that the stipends are provided, or they are at least being made a part of the policy decision making. So compensation, the digitalization aspects, the supply chain aspects are becoming more formal from a government standpoint. That's, I think, changing the narrative also at a broader level. Because from a volunteer to suddenly, there is, oh, this is a cadre which government is recognizing. It's also changing the perception within the community. And that will surely have an impact on the gender equation around this. I've also seen, and this, I don't think this can be measured in purely quantitative terms, but qualitatively, there are real experiences in the field where the same community worker, once this person has been enabled with a smartphone, whether it is coming through a partner support or directly from a government-led digitalization agenda like an electronic community health information system in Kenya, Uganda, Burkina, where we are involved, the community suddenly realizes that this person has been given a new tool, which is helping bring benefits to the society. It's a form of a recognition of the effort which this worker is making in the field. And that recognition is not by the community, but by the larger ecosystem. It could be government-led. And that suddenly adds strength and voice and weight to the voice of that community health worker. It's more of a recognition that you're someone important in the ecosystem. So when you say something, we will possibly pay more attention to what you are saying. That definitely is a very strong, societal change. And I should have spoken about it now that I recollect around the digital value. But this is that gender empowerment we are talking about. I think in years to come, this will definitely go to a very different level. I think to where we started and where we are, I think in another 5 years, this equation will completely change.
Yeah.
I think this will absolutely, make it an equal playing field, level playing field for everyone.
So I'll hold you to that in 10 years' time. So you'll be at 10,000 work days then. Maybe we'll see the change. Just I know you touched on that, and briefly, this is the very last area I want to touch on. I just like to get your high level, both of your opinions on the role that artificial intelligence or AI might play, especially when we're thinking about digital data and community health worker programs. Brian, I don't know if you've got any high level thoughts on whether you think this will be a positive shift, whether you envision challenges, or perhaps where you see this going in terms of trends.
It's right. It's a good question. I think
it's a vast question. I'm sorry. Yeah.
Right. Making any predictions about the direction that AI is going right now feels like a tenuous thing to do.
Don't worry, I won't hold you to it.
I'll give you the 2 week and the 4 week prediction. So I think it remains to be seen. Our approach at Dimagi, I mentioned earlier, we are a tech company, but we're like the most Luddite tech company I think that exists, and that we've, as various tech waves have kind of come and gone, and various groups got really excited about all the ledgers that came along with Bitcoin and those kinds of things, and that was going to solve a bunch of problems and whatever. And Dimagi's largely kind of stayed out of things until the sort of most recent wave of generative AI, because I think there is at like a very basic fundamental level the ability to respond reasonably to an arbitrary human input is a really powerful technology. I think it remains to be seen whether this will go well or not go well. For us, it was once GPT-4 was out and we were able to have reasonable handle complex instructions and the ability to operate in Swahili and Hindi and some of these languages that are kind of pervasive in some of the areas that we're working. I think that was a big step forward. We're doing a bunch of work trying to understand how we can further improve performance in low resource languages. So we've done a lot of work in Malawi with CHW. We've been doing some work in Western Kenya around Lwala. We've been doing some work in Nigeria and a number of other locations trying to improve the performance with low resource languages in large language models specifically. And at kind of a taking sort of a short view of things, we've been kind of pushing forward a few different areas. One is direct to client services. So we're building chatbots to talk directly to youth about sexual health and reproductive health. And then the second area is around supporting frontline workers. So we're doing stuff through CommCare Connect with training with community health workers. We're doing some stuff. We have some work in the US where we're taking some of the pre-existing programs for training frontline health workers to have difficult conversations, like end-of-life conversations with patients. Now they're able to role play with a chatbot to kind of practice some of that. It's relatively low stakes. They can get some good feedback. The models are surprisingly good at kind of doing some of that role play and then reflecting back and saying like, hey, here are a few things that you did great, and here's a couple areas you might want to think about for next time. So we're kind of exploring kind of doing that. And then the third bucket are just sort of general AI tools. So tools to help organizations to kind of summarize and support. And I think, we can imagine if you start at the individual and then you say there's a set of community health workers and then there's somebody who needs to supervise them and then there's somebody who needs to act on that data, you can imagine a conversational agent for sort of each of those and in between the layers. So being able to take large amounts of feedback, even as we were talking earlier about how to loop community health workers in and be able to get their feedback on the apps that they're building, having a large language model be able to aggregate and process and summarize some of that feedback suddenly it's reasonable that they can type in or even just drop a voice note with like, hey, these are my suggestions, like this thing isn't working and I'm frustrated by it or whatever. And you can bubble all of that information up much more quickly than you would previously, or you would have had to have some structured form and hope that their feedback fit into that structured form, et cetera. So I think there's a case for the kind of positive use of AI. And then just to touch on it, because I think we need to keep it in mind, I think there's also the sort of, the dystopian future that could occur, where we don't want to get to a case where it's only those who have means and support that are actually able to be seen by a real life health worker, and everybody else gets relegated to the robots. It might be that the AI models are better at certain decision support pieces and whatever, but as we talked about in the story earlier, that human connection and that human empathy that community health workers bring is incredibly important. That's in some ways more important than, or often can be more important than the actual diagnostic of things. And so, when AI is used as a tool to amplify human intent, and when it's kind of integrated into these very human systems, I think there's a lot of potential for benefit. And then we need to keep in mind the dystopian future where everybody else gets relegated to the robots.
No, that's fascinating insight. Kanishka, I don't know if you've got any
Yeah, no, absolutely. And most likely I'll be eating my words in a few months' time on this. But I completely concur with what Brian said. I think this is a space which no one can give a definitive answer as of today. I think this is a space where every 6 months, there has to be a reevaluation and assessment of how far it has moved. I think we are very quickly jumping on the conclusion that AI is here and it will solve the public health issues. I think the first and foremost is getting the fundamentals of technology right. These systems are at scale. Without having the right fundamentals, they're still being developed. So one of the things which I always question myself is that the current AI models, can they work in an offline mode? Can they work at the end user level, where there is no internet, the quality of the smartphones is not like the Samsung's S24, S25, these are basic quality Android smartphones. Do they have the computing power to run an AI model in an offline mode? If not, then there is a huge dependency on the internet. So how do we solve for that? And maybe in 6 months' time, as I said, I'll be eating my words. Maybe there is a new model which will come up. The second part is also the data models themselves. Are they even at the right place as of today? I think I was just reading a news article. There was an OpenAI summit, I think last week or a couple of weeks back, where all the global leaders had convened somewhere in Europe, I think Italy. And I think the Indian Prime Minister quoted an example that, you ask AI to draw, someone painting with the left hand or writing with the left hand. None of the AI models is able to do it today. All you get is a picture of, or someone writing with the right hand or painting with the right hand. And that is where the technology has progressed forward. But maybe it's, who knows, 6 months, a year, 2 years down the line where there's a better data model, which means more work has to be done on building those data models. I feel there is value in this, but I also feel that we are maybe jumping to the use cases too quickly in the hope that this is that holy grail which will solve the problems. I think it might very well solve the problems, but we need to get the data modeling right on this.
Yeah, and I think you're right from an equity perspective as well. If the models are being developed in North America, in Europe, there's a huge swathe of the population, but we need to be making sure from an equity perspective the models are being trained correctly. And also, I completely agree with your point about the fact that these things need to work offline. So yeah, it's too fascinating.
And also, I think the third component which I wanted to refer to is, what are we trying to solve for? What's the ROI around this? I mean, it's the same, question. What are we wanting the AI to do for us? We need to be really careful on that, because if we want to envision a world where everything is being done by AI, we might run out of money. We might not even have the resources to support that. So what is going to make the maximum impact? I think that has to be a very conscious choice by
Right.
the ecosystem.
Yeah, it's a really good point. It's an excellent point.
Yeah, great. This has been a very, very wonderful conversation. But just a takeaway question, both of you, how would you describe some of the prominent issues that have come out from this discussion that will bring positive change in the community health workspace?
It's a very fascinating space to be in. And some of us who have been a part of this longer journey in the last few years, I think will absolutely join me when I say this, that 10 years back, the conversation was around, or the argument was around, can the community health workers actually handle technology in their hands? Can they use a smartphone in their hands? That is where we also started as living goods. Like when we started giving the phones and the smartphones to the community health workers in 2014-15, that was the big question we also wanted to answer. Can this actually work? Fast forward 2025, I don't think this is even a question in the room. That's become the default. And that is huge success. That is huge success to every single person, every single organization involved in this journey. As I am a skeptic of AI as of today, even those skeptics have had their own value because they have helped refine the system in the last 10 years. But this is not a question anymore. That's where I think we need to think of where we want to be in 10 years' time from now. What type of world we are talking about, what type of community health world we are talking about, and what role digital has to play in that. For me, it still boils down, and maybe that's the techie in me speaking, getting the fundamentals of technology is so critical to this, because that is where the value will be generated, specifically now that the systems are at scale. Governments, have actually bought in the idea that this layer is important, and digitalization and professionalization of the community health layer is absolutely critical from a public health standpoint. And that's where the opportunity and the threat lies. If these systems work, it opens the door of unending possibilities of what the next level is. Maybe AI is the next level. But if these systems do not perform at the optimal level, that's also a threat of how digitalization of this layer will be considered in the long run. And that's where the question of ROI comes in for the funding community as well as for the governments from a policy decision standpoint. So we need more people who understand technology in this space, who want to make a difference at scale, and who absolutely want this to work. This is a very complex societal problem we are dealing with. It's about saving lives. So that's what I would say to your question.
That's great, Kanish. I don't know that I have a lot to add. I think I would start with where Kanish ended, which is to keep in mind what the end goal is, and the end goal is to improve people's health and livelihood, and ensure that everybody has kind of equal access to a good and long and healthy life. And I think keeping that in mind, everything else falls out from that. So the technology is there to support people who are on that mission, right? And Kanishka was talking about the importance of designing these systems and ensuring that they're kind of well positioned, and all of that comes back to what is, if you're thinking about ROI or you're thinking about the design of the system or something, what is that return? What are you looking for? What are you trying to accomplish? And even, I remember the early days of even before there were smartphones, even before there were widespread mobile phones, we were doing stuff on PDAs and working with populations with HIV. There was a lot of stigma around it, and you would go into a community and people would be like, "Oh no, I heard that device. You can point it at somebody and it can tell automatically if you have HIV or don't have HIV or something." And there was a lot of misinformation that kind of goes around with it. But like all of these things they're all people issues. They're all people problems, and it's all about communication, and it's about understanding what we're trying to achieve and being able to communicate that and kind of harness that. And the community health workers are an excellent example of that. These are individuals who've dedicated their lives and their careers to helping the health in their communities, and our role is really just to support them and to make them more effective and to make their jobs easier and better in some way. And so I think keeping that kind of fundamental, the human piece in mind and at the core of everything we do, will help us build better systems. It'll help us keep the return in mind while we're thinking about ROI, and hopefully lead to better outcomes and better jobs for community health workers.
Fantastic. Thank you both so much for coming on the podcast. It's been an incredible conversation. I feel like we've learned so much, touched on so many important areas. Just a huge thanks to both of you for your time.
Thank you for having us. And one last statement from my end. This is just a call as a technologist. Love and technology both take time. So let's have patience with technology at scale.
Right.
Yeah.
And thanks very much, Dickson. Thanks, James.
Thank you.
Appreciate it.
Thanks, man.
We hope that you enjoyed this episode. If you did, please consider sharing it with a friend or a colleague and leave us a review wherever you get your podcasts. It really helps others to find the show. And don't forget, episode 4 is now available.